So thank you again for sticking with the program. I gotta say, this is my favorite topic. I'm really passionate about regenerative medicine. And I tell you why. I practiced for a long time in the States where I had to go through the standard treatments because of all the lawyers. So I did all the diagnostic blocks, the radiofrequency, the cryo, the STIM, and then I fixed my patients with the non-standard regenerative medicine. And I think that is absolutely the future, regenerative medicine. You'll see in 10 years that regenerative will go like this. And maybe the rest, we'll see where they go. So the objective of this talk is to see the current trends and to see where steroid is really in decline. We are coming to realize that you can do steroid. It makes you look really good because the first steroid works like magic. But then the consecutive steroid shots work shorter and shorter and shorter, and then they don't work, and you run out of options. And regenerative medicine is coming up, is getting more popular, luckily. I want to talk little bit about biotensegrity, and I have this picture here about this house, because I think you need to think of the spine like this house that collapsed with the hurricane. It's not like one window breaks. It's not like a door breaks. It's the whole frame collapses. And that's how you need to think a little bit of the spine. And then we'll touch on what it means in the practice where you stick your needle to actually help your patient. So this article came out in JAMA, and they compared intra-articular triamcinolone versus saline, large number of patients, and what they found, after 2 years, the cartilage volume loss is big when you put triamcinolone, and the pain relief is the same when you put saline. So it makes me question, do you really want to put more triamcinolone? I mean, it speeds up the way to an arthroplasty, and which may be good, but it's not necessarily good for the patient. This came out in Lancet. It's a corticosteroid injection. It's a systematic review for tendinopathy. And the conclusion is that there is strong evidence that it's very good short-term and it's very bad long-term. And this is not going to be a literature review talk, so I'll just touch on a few articles, but there's much, much more out there now. And here is one more that came out. Essentially, we can conclude that if you use steroid for lateral epicondylitis, outcome is worse on the long run. So let's get to regenerative medicine. What is the concept? The concept is, as you age, your breakdown is more than your repair, right? Which is not the case with kids, right? They repair themselves so fast. And with regenerative medicine, you want to reverse that trend. You want to kind of improve the repair and maybe decrease the breakdown and tip that balance to a better way. And this is how it works, right? When you hurt yourself, you cut your finger, you activate your inflammatory cascade, and it results in tissue healing. Your finger will no longer be cut, but it will be cured. The way it happens is that you have a platelet activation, and that happens from the cell injury, the lipid leakage itself. And of course, the stem cells participate. You shouldn't think of the stem cells as they go there and they turn into cartilage or they turn into skin, but they are like the conductor, they're orchestrating this inflammatory cascade. And when it comes to our treatment options, this is what we have. We have PRP, which is directly platelet injection to the site, or it's also itself, the injection itself is causing cell injury. We have the stem cells that we can, again, put straight to the site, or it participates in PRP activation, or platelet activation. And if you're a doctor that don't have PRP, you still have the option of prolotherapy, which is essentially a hyperosmolar sugar water. It's a dextrose injected. But again, it causes lipid leakage through cell injury and goes back to the same cascade. Now, if you look at PRP, you put it in PubMed, and you see it is over 20,000 results. And then you try to narrow it down, you put randomized controlled trials, and you see it's still 91. So when doctors come to me and say, hey, we don't have any evidence, there's no studies, it's totally not true. Now we actually do have studies. We don't have enough studies, we never have enough studies, but I bet you that we have more for this than for appendectomy. Okay? So PRP and regenerative medicine is a hot topic. Now this is a summary slide from another talk I made, evidence-based review, evidence review. On the left, you see the quality of evidence. So anything higher up on the slide is better quality research. We can say that we have really good level 1 evidence, multiple systematic reviews for tennis elbow, for knee OA. We have okay evidence for patellar tendinopathy, for plantar fasciitis. Everything green is pro-PRP. Everything red is against. So we have studies against it. It didn't work in Achilles tendinopathy, and so on. So get to spine, because spine is my favorite. Knee and elbow works well, but spine works magic. So we do have level 1 studies for intradiscal PRP, for facet PRP, and for facet prolo, we have pro and con studies as well. Again, level 1, and of course, level 2, 3, 4 as well. And we have epidural PRP, SI PRP, or prolotherapy, again, level 1 studies in support of regenerative medicine. If I want to summarize similarly the quality of evidence we have, just like I did before, again, higher up, better quality evidence. We don't have much on the top row. We need more studies for spine. But we do have pro studies for epidural PRP, disc PRP, facet PRP, and so on. So this brings me almost to tensegrity. Here is a patient. It's a 32-year-old, healthy female, lifts a heavy box while moving, and she feels a pop in the back. And she develops immediate back pain, but nothing else. Can I ask you if you've seen a patient like this? Like, it's very common. Like, you see it all the time. And then these patients may not even come to you. They recover themselves. But if they come to you, then you do a physical exam. And it's very, let's say, non-specific. You find a loss of lumbar lordosis, midline tenderness. It is painful on extension and rotation, right? It tells you facet problems. And tight paraspinal muscles. So what's your diagnosis with this? I think if you ask a physiotherapist, it's myofascial pain. But if you ask an anesthesiologist, it's a facet problem. But the patient goes home and gets better with NSAIDs or without NSAIDs. But a couple months later, she develops occasional radiation down the extremities. And when you do the physical exam, you find essentially an S1 weakness. It's again a patient that we see all the time. Now, if you ask what's the diagnosis, you can even invite a neurosurgeon. It's a radiculopathy, it's a disc herniation. So it's really complex to see what is it that we treat. Do we treat the previously identified facet or the myofascial, or do we treat the disc or the nerve? Can I ask you how many of you heard about the tensegrity model? It's good, it's coming up. So tensegrity means tension and integrity, and that creating a balance. This is a model or a piece of art by Kenneth Nelson, the American sculptor. It's a floating compression. You can see that in this art, if you remove anything, you disrupt one of the bars or disrupt the cables, the whole thing will collapse. So the concept of tensegrity is this balance between the rigid elements and the flexible elements that are tensed. And you can see that here at the joints, where the flexible and rigid meets, that's where the biggest tension is. This is another example for tensegrity. It's nice and light and sturdy. And here you can see this building in Japan. It doesn't collapse if all goes well when the earthquake comes. But then you think of this building in Kathmandu that didn't withstand the forces very well. Many of you might have seen with the kids those toys that you can compress and it can regain the structure. So we used to think of the spine as a column. It's nothing else, just a stack of bones, and then you put the muscles, and then the muscles move, and that's it. But it's not true. It doesn't hold true. A spine is doing a lot of things. This is a model that you can actually find on YouTube. I didn't make it. It's genius. So the spine is able to stretch, right? And then get back to the same shape. It's able to compress, and you can rotate, and it always gains back the same shape. You can also see that these rigid elements don't actually meet. They are connected with the tensile elements. This is how it's possible to maintain a structure like this. And this is how it's possible for us to come into various postures to do the gymnastics that seems impossible based on Newtonian laws. And when you look into, let's say in this MRI, look into the anatomy, you understand that the body is built based on these forces that it has to resist. You can see that, for instance, at the iliolumbar ligament, it's connected from the transverse process to the iliac crest. But then the glute medius is built as a continuation of the force, and then it continues in the leg muscles. Similarly, the Achilles attaches on the calcaneus, but you look at the trabeculae, it's lined up along the forces and continues in the plantar fascia. So what it really means is that you cannot really get injured at one spot. It's not like you have a facet injury. It's like this fabric. You pull the fabric, and it breaks at some point, but the other parts also get weaker. So we need to think more like in a system of the lumbar spine. So looking at the spine and the function of these ligaments that keep the bones together, the supra and the interspinous ligaments, it maintains the lumbar lordosis. It prevents the spinous processes from opening up. It also prevents some of the rotation. And the facet joint is, of course, it contributes to the stability, but you want to think of it more like a wheel bearing. It guides the movement as you rotate your spine. And this is a big one. It used to be completely forgotten, and now I see people are becoming more aware, the iliolumbar ligaments. That's a really big ligament that connects the L4-5 transverse process to the ilium. It prevents the L4 slipping forward on L5, prevents the L5 sliding off S1. So when you see an enterolisthesis on the MRI or the X-ray, you can already tell that there is a biomechanical problem. Either painful or not painful, that bone could only slip forward if there's an instability. And further, we have the fascia, all these fascia and ligaments, and essentially the bony structures kind of float in it. And some of our biggest muscle, like the traps, the latissimus and glute max, actually don't attach on the bone. They attach in the fascia. So going back to our patient, what is it that he has? Right now, with the facet pain, the disc, or the radiculopathy and the myofascial pain, it is turning out that he has a little bit of everything. This is what happened to this patient. When she lifted the box, let's say what the pop was, she popped the supraspinous ligaments. That in itself is painful. Now, if there is a forward pressure on the disc bulges out. At this point, you can have a discogenic pain. At this point, there is pressure over the posterior longitudinal ligament, very highly innervated, if you read the Kushlik study. So that in itself is already back pain. Not to mention, if the spinous process is separated already, there is a pull on the facet. That hurts too. And if things get worse, the disc bulges out more, that's when the patient presents with the radiculopathy. This is a paper recently published, 21, that essentially reviews this process. And this image shows you what you observe in the clinical practice. The patient comes to you initially with a usually L5, S1 facet problem. As time goes by, as multiple facets get involved, SI gets involved, and eventually you're here with the completely loss of lumbar lordosis, compressed disc, complete degeneration. So the way this builds up is that initially you have a ligament laxity, facet arthropathy. And that's when you go to the anesthesiologist, you get a medial branch block, you get the denervation, and it's a bit better. Of course, because there's an instability, you also have the muscle spasm. So again, you go to your manual therapist or physio, and they can take care of the muscular pain. But it's not taking care of everything. If there's a disc herniation, that's the other problem, right? It can create this nerve irritation, compression of the nerve, or chemical irritation. That's when you get your epidural steroids and the epidural lysis. So that's how I think low back pain builds up. And if you focus on one individual group, you never get the full relief. You always get a partial relief, not to mention a temporary partial relief. So this is a cartoon version of an old Indian art. It really, if you close your eyes and try to figure out what you're looking at, there's going to be, of course, a misunderstanding between us. That's why the neurosurgeon, not necessarily understanding the anesthesiologist. So this brings me to treatment. How do we treat these patients now that we understand that it's a biomechanical problem, a system problem? Will you choose to treat the facets? Or will you choose to treat the wires, the nerves? Or do you want to treat the discs, like this earthquake? I find it really nice, this picture, the Loma Prieta, right? The discs, the windows went, the frame remained. So it can present different way by each patient. This is what more and more people do now, and it makes so much sense. You treat everything that you think is damaged. So you will put needles to the supraspinous ligaments, okay? Because that's a very important stabilizing structure. You will target the facets. You will target the SI joint with the capsular ligaments. You target the iliolumbar ligaments and the thoracolumbar fascia. That's like a basic pattern to inject. Of course, you need to modify this based on the actual patient that comes to you. And it almost doesn't matter what you inject. You can inject PRP or prolotherapy or stem cells. Your patient will do much better. This is a study by Kirchner. It's been criticized a bit because it seems unbelievable. He injected multiple targets, intradiscal, facet, and transforaminal epidural. But his outcomes are amazing because at 6 months, 91% of the patients had excellent score. You know what? I totally believe him because that's the outcome that I think we are able to achieve and I achieve with my patients. And this is a Atluri study. It's unpublished. I listened to his talk at Toby. He compared 80 patients in the prospective controlled study. He injected stem cells to the disc, epidural, and SI, and compared to conservative treatment. And look at the ODI outcome. It's 68 versus 7. I hope this study will come out, and I really believe that it is what it is. So, as a conclusion, we need to understand the biomechanics, and then it doesn't just apply for the low back. It applies for knee, it applies for understanding, for other areas, to understand the mechanism of injury. Then you will understand the anatomical structures that belong together and part of the injury. It could be trauma or also chronic wrong posture. You will understand what to inject. And if you put your needle to the right spot, you can restore the biotensegrity. And you can take care of the pain. You don't have to take out the nerves. You can just help what's broken. Of course, we need more research. Like, yes, we need more research in every area. And finally, I'll show you my long-term follow-up. It's a case study. This woman was 24 when she first had low back pain. She couldn't sleep through the night and always had to go in child pose. It took a long time for her to diagnose herself. And then she underwent a couple of PRP and prolotherapy injections at the lumbar facets and supraspinous ligaments. And that patient has been pain-free, low back pain-free for over 20 years. Thank you very much for your attention.